Good morning, everyone. Good morning. Have a seat, please, for those that are still standing. Thank you so much for being here today. We're very excited for this special opportunity. Today is the 3-year anniversary of PHIRI. And PHIRI is the Population Health Information Research Infrastructure. So welcome to those that are here face-to-face. It's really nice to see all these familiar faces. And also welcome to those that are joining us online. So be aware that we also have a lot of participants online. So when you have a question, always speak in the mic and present yourself. That would be wonderful. I am Petjana Bogert. I used to be the PI of PHIRI. So we have a wonderful team working on this project. And now I am working for the European Commission in DG Santé in the Unit of Health Security. So that being said, we also have a Slido that will come up on several opportunities. So keep your cell phone close, but not too close, because you want to be listening and looking at everything that's happening today. And yes, we have a very interesting program for you today. We will have a great opening, then we have some keynotes, so we split it up in a specific session. We have a keynote bringing us a bit back to the basics and what is essential in health information and a bit explaining about PHIRI. Then we will be talking about powerful tools to boost the reuse of health data, which PHIRI is all about. Then we will go to a short intermezzo talking about strengthening the EU health workforce, because of course the workforce is essential to overcome any crisis. And then we will be talking, we will have a short video about the achievements of PHIRI, and we will continue with the topic of strong health information systems. And then we will have a final intermezzo about building collective intelligence, the PHIRI Rapid Exchange Forum, and we will end up with a wrap-up and closing messages. So now it is my pleasure to introduce to you Dirk van Rademakers. He is the chairman of the management committee of the Federal Public Health Service in Belgium. And during the COVID-19 pandemic, he served as the head of the task force for the COVID-19 vaccination strategy. Welcome.
Thank you. Good morning. I listen very well, so I can use the mic.
Yes.
Okay. Dear colleagues, ladies, gentlemen, it's a great honor to open this important conference. And the organizers especially asked me to focus on my own experiences during the COVID crisis. I didn't dare to ask them, did you mean during the day, during the night, or not during the weekend, because quite rapidly there was no distinction between the days of the week. So we just were in, yeah. But it's a great honor to be here, and I think we're focusing on a specific topic that is quite important at the moment that indeed we enter into a health crisis. And like every natural disaster, we can not always accurately predict when a health challenge, such as a pandemic, will emerge. Moreover, dealing with both direct and indirect effects poses major challenges for policymakers, our politicians, but also for you as researchers and, of course, for populations and the healthcare sector. I think that the still ongoing COVID pandemic, for those who already forgot maybe. Sorry, Jorgen, I mentioned the word COVID. Gave us numerous lessons learned. Currently in Belgium, a very thorough evaluation of the COVID response of Belgium is being performed by OECD. And we will have those results probably by the end of this year. So a little bit tension going on in some political heads probably. But I think that we can already formulate some conclusions, especially from the public health perspective. First of all, what about the performance of our healthcare system? They are, of course, built to improve the health, to care and cure for individual patients. But we also know that they're not really built to really improve the health of a whole population. And they were highly challenged during the COVID-19 crisis. And I think that the resilience of our healthcare systems, well, you can look at it from two sides. I had the honor, between brackets, to be in the medical director of the large hospital that had the largest caseload of Belgium. It started all there. And no, I didn't go to Switzerland for my skiing trip that year, so I didn't bring it back. But that's where it all started. And again, it was a special experience. So I think if you look at our resilience, I think that we can be very proud of the tremendous job. The things I saw was really incredible. That was done by our nurses, our doctors, many others. They did things they've never done before, and also, of course, in primary care and nursing homes. It was really excellent work they did. So I think we can be very grateful. Also, we developed this vaccination strategy like all other countries. And for those that are not Belgium, Belgium is top ranked. Finally, if you look at the number of vaccines administered, well, there is one specific thing that we tend to forget. It's not about strategy. It's not about political decisions. It's about all those volunteers, all those people that worked in the vaccination centers and administered those vaccines. So, like in a war, you need soldiers, and there I think we can also be grateful. On the other hand, we also learned that our preparedness and specifically our capability and the governance of dealing with such a public health crisis was not always up for the task. And that's a very neutral statement. And we also saw quite rapidly a second pandemic emerging of non-COVID patients, especially also cancer patients where care was postponed. And we have good data, Belgian data also about the consequences of that deferral and underuse. Now, what are we here for today, of course, is what about data? I think the COVID-19 crisis demonstrated very rapidly that we really need immediately solid science, solid data, and also trustworthy, valid data. Their translation, of course, into knowledge and policy, that's still another thing to be discussed. And I think it's not only about data, it's also about intelligence. You need really clever minds to interpret these data, and of course, you need to have a transformation or translation towards our policymakers. What did I witness? Very strange things. In a hospital, you see patients coming in rapidly. Your intensive care unit of about 50 beds, completely filled by strange people, strange patients with kind of a pneumonia we never saw before. And in the first era, there was no evidence. You probably still remember some drugs that were pushed by some gurus. I call it quakery, but okay. That's because I'm a little bit evidence-based fundamentalist, so excuse me. You still remember hydroxychloroquine, probably. For the veterinary people in the audience, we even considered ivermectin. And a lot of other stuff passed by. Second stage, also strange. Normally, during the evening, if I have time, I go to the BMG, the AMA, all peer-reviewed journals. We stopped doing that. What did we read? Preprints. Suddenly, our evidence-based world was full with preprints. And of course, all kinds of guidelines, because there was no evidence. And there I think I can mention that Cienzano did a tremendous job, and they really provided us with very good guidelines that were read by everybody. Thirdly, in our vaccination strategy, there it became clear that we really needed solid data, solid evidence, not only to do the follow-up, what's going on, but also to look at the consequences. What were we doing? And I think that we can say that we based our prioritization for the primary vaccination on epidemiological data of Cienzano. I'm still using the slide of the mortality data of Cienzano, wonderful, but also the international data, of course, that we gathered at European level. And I think that Belgium was one of the few countries, maybe the only one, that was able to, after the elderly, to prioritize people at high risk, like oncology patients, diabetes patients, and so on. Some say, and it's a hypothesis, Belgium was also one of the few countries that already had a normal life expectancy again in 2021. So some say, we will never be able to prove that that's because we were able to vaccinate our high priority patients before really the next waves kicked in. I think that we have a lot of examples that indeed exchange and expertise is invaluable, and we need much more infrastructure and a very strong network to ensure that there is a very rapid exchange of information. International collaborations, like the one we're discussing today, is paramount. I think that we learned that exchanging data at EU level, and even larger than that, is very, very valuable. We took a lot of decisions based on international data. We performed benefit-risk analysis. To give you one example, do you still remember the discussions on the different vaccines? mRNA versus AstraZeneca, Johnson & Johnson, and Janssen, vaccine. In Belgium, we decided to continue with AstraZeneca. We introduced certain age limits. In Denmark, based on the same data, but also some emotions, I think, they were leading the vaccination, really, on top of them. When they dropped AstraZeneca, of course, we know what happened. So if you calculated benefit-risk impact on mortality, I think we took the good decision. So that's certainly the subject to discuss with also the brilliant heads in this audience. I think we already showed, Europe learned that you need European strategies, European data. And not like we saw in COVID, that every country was dealing with the vaccination strategy on their own. In the monkeypox, MPX, sorry, but everybody's still saying monkeypox strategy, you probably saw that we were able to develop a European vaccination strategy, and we discussed that at the level of HERA, and the majority of countries implemented the same strategy. So to conclude, I think that the impact on public health services in general, so also on researchers of health crisis, deserves much more attention. We need much more emphasis on the need for preparedness. And we have an opportunity, we still have, I think, at this time point, and also how the generation of scientific evidence is performed and should be there from the start. Health challenges such as pandemics do not only concern patients, not only concern healthcare sectors, but especially the health of populations, public health. And that's, in a lot of European countries, something new, which is, I think, in my opinion, finally up on the agenda. I think that in all basic trainings, much more attention should be paid to public health and public health basics, health professionals, but also future policy makers, and that's urgently needed. That means that we should further increase our efforts in what I often call the development of pandemic intelligence at the national level, but also certainly at the European level. I think that PHIRI can play an essential role in this evolving landscape of health data, and even more in making those data talk to policymakers. But you will hear more of that in the keynote of Dr. Nienke Schutte. So to conclude, I think we're up for a very interesting conference today, but I would like to thank you, everybody in the audience, for all your efforts during the previous years, and to be sure we're counting on you also for the future. Thank you.
Thank you so much, Dirk. I think we've heard already some words that will come back a lot today. We've been talking about resilience and gratefulness. I think a thank you indeed for all the hard work, but also all the workers all around COVID-19. We talked about, or I heard, exchange and expertise, and I think indeed that's really key, having this international collaboration and the need for European strategies. And finally, I really enjoyed hearing about the health of populations, because indeed, when we saw COVID-19, of course, the individual is important, but the impact on populations is very important to be able to assess, understand, to have indeed this data talk to policy. So thank you so much again, Dirk, for being with us today. And now it is my pleasure to introduce Nienke Schutte. She's head of the EU Health Information Systems Unit at Cienzano, which facilitates the exchange of health information across Europe by leading and participating in major European projects in health information. And currently, Nienke is also the PI of PHIRI. Over to you.
Thank you, Petronio. Yes, so thank you for introducing me. So on behalf of the PHIRI coordinating team and on behalf of all the PHIRI consortium partners, I would like to welcome you to our 3-year anniversary. So I don't have to introduce myself anymore. I'm Nienke Schutte, the PI of PHIRI, but also the head of the Health Information Systems Unit in Cienzano, which is important to mention because we're leading there many European projects in health information, and we're also focusing now on the national level on the implementation there of health information strategies. PHIRI is the flagship of our unit, and I'm very grateful to welcome you all here to celebrate its 3-year anniversary. There are many anniversaries going on, actually. I think last week there was the anniversary of the Austrian Public Health Institute, 50 years. We had the European Public Health Alliance celebrating its 30th anniversary. Yesterday, there was, of course, a jubilee of the observatory. We have 2 representatives of the observatory here today. So I hope you're still awake and ready to party with us to celebrate our 3-year anniversary. So I'm sure you've heard this many times before, but I would like to take you a little bit through the abbreviation PHIRI, or PHIRI, of in het Nederlands PHIRI, or en français PHIRI, of Deutsch. Anyone? PHIRI? Everybody pronounces it a bit differently. But just to be clear what we mean by health information, because I think that's what we're talking about here today. So health information is all the information, the data, the evidence that determines health, but also supports and facilitates research and policy making. And in this keynote, I would like to set the scene for today. And of course, the upcoming panels and the intermezzos that you will be hearing from. By reflecting a little bit on the title of this event, From Data to Public Health Actions. This title implicates that we talk about a process. We're talking about a sequence of events. So you can ask yourself, is this a straightforward process? Is there a right chronological order to these steps? Which steps are already in place? What elements are missing? Let me see if I can move to my next slide. Yes. So when we talk about processes, we are describing a conceptual sequence of events. And this is, for example, captured in this pyramid by Akerhoff. So I will talk you a little bit through it so you understand how I want to set the scene for the remaining of the day. So data, it represents the basis of the period. These are properties that tell us a little bit about objects, events, environments, etc. Then we have information, because data are of no value when they're not processed in a usable form. And then after that, they're functional. And then we have knowledge. So knowledge can be extracted from the information. And sometimes you need to even combine information from different areas to arrive at knowledge. Last, on top of the pyramid, wisdom. Wisdom is the ability to create development, to increase its effectiveness. And of course, it is the ability to make well-informed decisions. Now we're going to add a little bit to this pyramid to actually create a system. Because this sequence of steps is captured within this one big system. And it's a connected whole. A system has value. A system creates purpose. In this system, we go from data, let me click, to public health actions. So how characterize a system that describes health information? Well, we can describe it here as an integrated effort to not only collect, but process, report, and use data and information and knowledge to support decision-making in policy, in practice, and in research. And the total of resources, of course, that need to be there to support this process. And a health information system, a solid health information system, plays a crucial role in responding to public health challenges and population health challenges. And maybe this is interesting to mention. In a recent PhD defense, actually the notion of this being a system was challenged by a very well-known professor in European public health from London. And he said, okay, maybe we are not far enough to actually already speak of an integrated effort. What about the fragmentation and the substantial inequality that exists and all the issues with timeliness and usefulness? So in Europe and its countries, we all know that we need timely, sound and high-quality data, health information to support policymaking, to strengthen policy actions in prevention, in healthcare, but also to improve individual health outcomes and population health outcomes. And both the European Commission and also the Council of the European Union already a couple of years ago, many years ago actually I have to say, expressed the wish to examine how to align the efforts in the field of health information activities in function of coherence, coordination, but also data collection, processing, reporting, benchmarking and comparison, capacity building, but also the transferability from health information to policy. Now, I would like to welcome to the stage, the digital stage, Bridge Health, the Joint Action INFACT, and now the Population Health Information Research Infrastructure. So we start with in Bridge Health in 2015. So this project actually concluded that a research infrastructure can be a very, very valuable tool to support the goal of working together with regards to health information activities and to have more coordination with regards to these activities. And bringing together networks, not only within member states, but also across Europe, and also international organizations, such as the WHO, such as the OECD, such as the Observatory, and of course also in collaboration with the European Commission. And then in fact, in the joint action, we started to pilot the different elements that are part of this research infrastructure. And now we arrive here at PHIRI, where we really implement all the elements that we found that were interesting enough to be part of a research infrastructure, to arrive at a platform with tools and services to support population health research. So what does that entail? So here we are focusing on, I'm starting at the bottom here, powerful tools to boost the secondary use of health data. What is needed to reuse health data that has already been collected and actually make sure that we translate this into information, processing, and then use it to create information, knowledge, and have the wisdom to make powerful decisions? How do you build collective evidence? How to strengthen the European workforce in the fields of health information? And of course, how do we build stronger health systems? I'm not sure if you've already studied the brochure that was on your chair, but these are actually all of the panels and the intermezzos that we will be addressing today. And these are all the elements that make up PHIRI. So going back to this pyramid, our conceptual sequence of steps and events. And PHIRI is there every step of the way to support researchers in their activities, to generate the best available evidence, to support policy and practice. Now, let's take it into a bit of a wider perspective. Because we all know that the European Commission is aiming to build a stronger European health union, aiming to, for European countries to be able to prepare for and respond to health crises and health challenges and work together to improve prevention, treatment, etc. And one of its central building blocks is this European health data space. And in May last year, there was a proposal launched for a regulation for this European health data space. And this European health data space is intended to facilitate the secondary use of health data. And PHIRI actually has a very large added value to this European health data space that will be built. How? So PHIRI can provide key services, both for the data provider in terms of, for example, metadata as a service, metadata cataloging, proxy data, sandboxing, but also for the researchers, because they can do distributed analysis of very sensitive health data through virtual labs, computational environments, etc. And of course, there's also capacity building, guidance, best practices on how to operate all these European health data services to allow researchers to really get the most out of what will be set in place. And finally, of course, strong networks and platforms to collect information, to start research projects, to start research collaborations, and to share information, expertise, and knowledge. So, in the end, let me conclude that PHIRI will have the ability to generate development, to increase effectiveness, and have the ability to provide policymakers with the best evidence to make well-informed decisions, and then, in the end, reach the wisdom on top of the pyramid. Thank you.
Thank you so much, Ninka. I don't think any of us have much to add to that. It really was a really nice introduction to all the different topics that we will be addressing today. So I would say let's dive in. Let's now go into one of these topics in more depth. So the next topic is powerful tools to boost the reuse of health data. And in order to have powerful tools to be able to reuse health data, there is one abbreviation I think that everybody in this room knows, and it's called FAIR, Findable, Accessible, Interoperable, and Reusable. So FAIR catalogues and federated architecture is key, and we will explore how population health data can be made more fair, more findable, more accessible, more interoperable, more reusable for research and policymakers, and how PHIRI contributes to this aim through the European Health Information Portal and its federated infrastructure for population health research. And highlights of PHIRI will be presented. So it is my pleasure to invite Hanna Tolona. She is RDI Program Director at the Finnish Institute for Health and Welfare in Finland. And to invite Enrique Bernal Delgado. He specialized in public health. In 2003, he founded the Data Science for Health Service and Policy Research Group at the Institute of Health Sciences in Aragon, Spain. So have a seat, make yourself comfortable. And while you're preparing, we will start with... normally, should we have the Slido first? Normally, there should be the Slido first. Okay. Well, then we'll go straight into presentations. The floor is yours.
Thank you, Petronil. So with Enrique, we will guide you through the powerful tools for the data use on the PHIRI, what we have been working on. And starting with the problem settings. So we all know that countries hold a huge amount of data within themselves. There's mortality data, hospitalization data, vaccination data, healthcare resource data, so forth. Many countries also have survey data additional to the administrative data sources. But this data, in many cases, it's really fragmented. It's within the different organizations, which are not always talking to each other, which makes it really difficult to find and use that valuable source we already have existing in countries. And the big issue is that even though there would be collaboration between the organizations, the data rarely is properly catalogued and findable for the secondary use. But this is just one part of the problem. And Enric will guide us through with the other problems we are facing with the secondary use of the health data.
Yeah, because in the end, when we want to use it, is when we find the problems. So when you find the data, you can reuse it, and then happens what happens in this slide. Very poor in there, many, as you can see, a harmonization in data collection, a standardization in data creation, poor data set integration, so you have to manage. Then you have different data protection officers in your way, and the sensitivity they have is different. So some of them are very adverse to risk, and others not. So the interpretation of the GDPR are different in that case. And then when you find people around you helping you with the data extraction, the data transformation to your needs, then you find uneven technical skills all around those who host data. So, and there is a underlying element in all these things, which is when we use real world data, as in COVID-19 in the end, what we needed is provide rapid responses to rapid questions. You cannot do, randomized clinical trials. You have to extract data that is available, real world data for real life decisions. Then you find another big hurdle. This data is potentially sensitive. So in PHIRI, we've tried to solve these questions. Let's see.
And what we actually did is we started thinking that how we can improve the findability of the data. And our big achievement is the Health Information Portal. It was the joint effort of the member states and the PHIRI team to do the collection of the information in one place. So we have the internet portal, which is supporting the FAIR principles, findability, accessibility, interoperability, and reuse of the health data. This portal includes a collection of the catalogues. You can have much more information on the booklet you have on your seats on the catalogues. Those catalogues also are built in a way that they use the existing standards, so which makes them more interoperable with the other catalogues and other data sources around. And we have also made a huge effort to make that digitally interoperable. So it's not only that the metadata is interoperable and findable, but we have used the schema.org behind the scenes of the catalog that the information can be findable through the search engines as well. And it's really important that documentation is properly done because that's the key to start the findability and usability of the data. But as soon as we find the data and we have it in our hands, then we come to the second problem, how to use data without tempering with the GDPR limitations on that.
And the option we followed was to develop this federated research infrastructure that along the project has been tested in 3+1 use cases. So real life questions on COVID-19, the direct effects, and having a response, not in real time in that time, because in this case was a piloting process of a research infrastructure. But we were able to test all the elements, key elements that overcome the problems that in the previous slide. 3 pillars for this research infrastructure. One of them, we don't move data from the place they are hosted. We move the code to the place So the data visiting principle, we call it. We need a strict methodology in terms of, the governance of the question, the governance of the problem you want to solve. And then we follow this pipeline that allows you legal, organizational, semantic, and technological interoperability. And to highlight some of those steps, we start from a common data model, a fitting for purpose common data model that in the end provides a sense of what is exactly the data that you need, making life easier for the data protection officers. Then you include elements of standardization and data quality in this workflow. And then you provide in one of those with a solution, which is the computational architecture that follows this topology that you see there, that in the end, you contain everything in the pipeline in a technological solution that is implemented, is deployed in the premises as a secure process environment, providing with the results. So these are the three pillars to solve the questions and to allow the use, natural use of the data that is potentially sensitive.
But we are not on the final goal yet, so there is still steps to take in future as well. And big issue is that not all the countries have that data catalog. In PHIRI, we have now get really good head start with that. And it's important that we properly and openly document our data. That's also for the open research principles, that you have deep open documentation. And that makes the future research much more cost-effective as well, but also ecologically more sustainable when you don't do new data collections over and over again. We also have to remember that EHDS regulation proposal, still in proposal phase, is saying that each country needs to have the data catalog, national data catalog. They need to use the standardized metadata descriptions for that. And since the idea is that those data catalogs can be combined, there needs to be interoperability on those, and we need the national access bodies. And what we have now done within the PHIRI is supporting all these actions. We have the national nodes, which have been working together to collect standardized format of the data catalogs within the health information portal. So we are already one step closer to the requirements of the EHDS. And with that easy access and use for the health data across countries, we can support high-quality research, which then supports the evidence-informed policymaking.
You may call me naive, but my ambition, I think PHIRI's ambition would be to be interlinked between health data at EU, the European health data space for secondary use, and the European Open Science Cloud. And we may play some roles in there. Some of them have been highlighted by Nienke in the keynote, or Hannah now, in terms of cataloging. But let's imagine the population health researcher, basically the needs of this guy that is trying to do research with data that exists, and is under this circumscription, and is under this regulation, and is part of a new governance that is the health data at EU. So thinking of these people, ourselves as scientists, I think that PHIRI could well be an interface between the researchers' needs and the European health data space, where data will be visited at some point in time. And there are many potential services we can provide to the community of population health researchers while keeping contact with the health data space and the European Open Science Cloud. Horizon scanning, who is salient, who is coming in the pipeline of research in population health, for example. Services of discovery. I mean, the data catalogs will contain data sets, but there are many other things to discover. For example, the work done by others in other places, existing tools in the epidemiological side, or the projects that provide all the tools of use for these people. Other type of this service could be the legal and ethical, support service for researchers to make them aware of the avenues to follow the time they want to go there. You may also provide services that allow them to develop their analytical pipelines using, as Nienke said, sandboxes with synthetic data, etc., etc., etc. So in the end, something interlinked with both as an interface between the final user, the end user, which is the population health researcher in those big infrastructures existing or likely existing in Europe. I think that's all right. We did quite well.
We did quite well with short time period we had, actually.
On the dot. You did excellent. All right. So then I'm going to steal that clicker again.
Yep, sorry.
Yeah. And then we go to the Slido. So here we wanted to ask your opinion. How far do you think we have already progressed in the health domain with regards to FAIR? Because we all know there are some areas where FAIR is already very institutionalized and easy. Let's think about banking. Your banking data is available anywhere, at any time, in any country. It's easily transferable, this data. It's highly secured. And it's also sensitive, like health. It's data you might not want to share with everybody. And it's the same for health. So what do you think? How far do you think we have, or where we have gone, and how much we have progressed in the health domain? In the meantime, while people online and here in the room are answering, I will introduce our panelists for this session. So I will invite Jérôme, Jana, and Nicholas to come and have a seat. So Jérôme de Barros, you can come and have a seat. Jérôme de Barros is policymaker at the European Commission. He works at DG Santé with over 10 years of experience in digital health programs and policies. Then we have Jana Makadonska. She works as a program manager at the health research unit of the European Health and Digital Executive Agency, HADEA. And we have Nicholas Bloomberg. He's director of Elixir, the pan-European distributed research infrastructure for the sharing of life science data. So let's all have a quick look at what people have answered. And so we think in the health domain, we have achieved quite well in terms of findability. Okay, that's already a strength. Accessibility or reusability is in discussion. But you can see there's a lot of progress there to make. And then we have interoperability, which lags a bit behind. So maybe we can start with a first question to the panelists. How are you putting FAIR data principles into practice? And can you reflect from your own expertise and domain?
I can go first if you want. Is it on? Yes. You can hear me.
Perfect.
Good morning, everyone. Thank you for having me here. It's a pleasure to speak for the first time, actually, at the PHIRI annual conference. I will share my experience as project officer and program manager of collaborative health research projects under Horizon 2020 and Horizon Europe. And I will principally talk about Horizon 2020 projects which have ended or are about to end, because this is when we can see what they have achieved from the promises. And I would like to take the perspective of a project that is not in the area of infectious diseases or population health, just to compare a bit the practices with what Enrique and Hannah have just presented. This is the UCAN project, which is about genomic oncology, coordinated by the Barcelona Supercomputing Center. So the intention there is to have a federated network, but really at the discovery level, not at the analytics level, for aligned and interoperable nodes to help the homogeneous analysis, management, and sharing of genomic oncology data. So they integrate genomic data together with phenoclinical data. And the difference I find compared to PHIRI, if I understood correctly, this project actually works with hospital centers, and they have gone, the innovative part was that to enable findability, they have worked with the clinical centers, with the sequencing facilities, to actually first compare the genomic analysis strategies, to benchmark these, and to create pipelines on site so that these can be comparable and analyzable together. At the same time, what I found different from the projects from the same topic, this is the topic of the EU-Canada flagship collaboration of human data sharing, was they actually requested the healthcare professionals to take care of the clinical metadata, be it linked to EHRs or data coming from clinical trials. And of course, as in all these projects, they created a metadata catalog. But really, they approached discoverability a bit different. Access is actually granted through the European Genome Phenome Archive and other such repositories at European level, and they promise, but yet to be seen, I still expect their final report, if they're going to deliver a service in which they can receive requests for access to data and respond to these requests for genomic data and associated metadata. And they outlined a few challenges. Of course, interoperability is in a way enforced by the fact that they use the standards of the Global Alliance for Genomics and Health, and reusability, while they placed a lot of effort in creating ethical legal frameworks for the nodes in which they operate and codes of practice. So this is what I want to share here. Usually our projects from this generation, so 2018, topics of 2018, they finish with the metadata catalogues. Some of them promise federated learning. We'll see if they have delivered this. We have new generations of projects who may be able to deliver this, but not at this stage. So I hope that answered the question.
Yeah, maybe I can pass the floor to Nicholas. Does that sound familiar, some of the struggles that are being described? How did this work for Elixir?
Yeah, no, it doesn't. I think a lot of the items that came up in Hannah and Enrique's presentation really echoes with what we've done. So one of the flagship projects from Elixir is what we call the European Genomics Data Infrastructure, which is really about releasing human genomic data, which is increasingly being generated within the healthcare system, and make that available for research. And that's also fundamentally the architecture is the same. It's based on enabling local sites to participate in a large federated infrastructure. And I think the driver for that is not only data protection, it's actually trust. So the individuals, the patients or the volunteers will have a relationship with the local institution, whether it's a hospital or it's a research center. And when you allow that research center to participate in large-scale European initiatives, that's a very different conversation you have with the individuals. If you say that your data, we will take your data, we will bring that as part of the Finnish cohort to a large European collaboration, is quite different from saying, oh, we will send your data to a server in Brussels. And so I think that trust is really one of the real drivers for the federated system. And then the benefit and the challenge of that is that you build capacity across Europe for managing and participating in this data. Mm-hmm. But I wanted to pick up another thing that resonated with me, if I may, just a second, was the Slido query, the sort of ranking between findability and then reusability and accessibility and interoperability actually coming last. And that echoed, so I was part of the group that published the original FAIR paper, and we had a lot of very intense discussion on that very thing, whether or not you should prioritize interoperability or just putting the data out there. And I'm very much in the camp of just make sure that you can put the data out there and drive some research projects around that data, because sooner or later researchers will find interesting ways of reusing that data, and that will inform the long-term interoperability. And I think that's another thing we have seen, is that the large data resources, the older they are, the longer they've been around, the more interesting science there's been generated around them. And actually the quality, the oldest archive, the data format was invented in 1972. It has its challenges. There are many aspects of modern biology that isn't captured there. And yet that's where we see this large breakthrough in AI with AlphaFold is coming from that data set. Mm-hmm. So I think that notion of getting data out there, making it used, and then let the use inform the interoperability is really quite important.
So when it comes to FAIR, more than a focus, these FAIR principles have really been embedded into what we proposed in the European Health Data Space proposals in different provisions, but also in the development of the infrastructure for secondary use. Starting with findability, Enrique and Hannah mentioned the catalog, for example, and as we are developing this catalog for the European Health Data Space infrastructure for the pilot, we are building on what was done by previous projects. We are involving similar partners. This is how we can ensure other of those principles, such as interoperability. So ensuring that we have people like Enrique, that we have good collaborations with national agencies that have those national catalogs that will need to create those as part of legislation, is how we can ensure that those FAIR principles are embedded into what we are developing.
So Nicholas was talking about maybe like a bottom-up approach, and then we're talking about a top-down approach. How can we find a good balance there at motivating different data owners to make their data fair, putting it out there, and at the same time providing good structures to allow to do that, covering the health area?
I mean, from a top-down approach, as you said, so the legislation requires data holders to make the data known. Findability, the first requisite is really to make sure people know this data exists in the first place. And in this process, for us, it's really important to ensure that it's in a common way, in a way that is also not too time-intensive, resource-intensive for those that have to comply with these obligations. At the same time, we want to make sure that this description still is relevant. And for example, by pairing it with other types of description of those data sets. So some top-down needs to happen. That's what legislation does, but there's obviously other incentives that can take place to make sure that these are also implemented through other ways. And
I think Hannah first, and then I'll go to Nicholas.
Just reflecting what Nicholas and Jerome is saying, it's really important that we also can do the learning by our peers. So in Finland, I would say we are a little bit forerunners in the data cataloging. And my colleagues from the FinData, they are traveling quite a lot to different countries, telling what we have been doing, what we have learned, what's working, what needs to be still developed. And that's something we need to increase much more now when the regulation is also coming, that we dialogue with each other and with the countries to learn from others and not repeating the same mistakes that one may have done at some stage.
Nicholas.
Yeah, so I'd like to echo that, and I think we see that in the same in the genomic space. Simple things like staff exchange programs have been absolutely critical, and a lot of the sort of knowledge transfer happens through staff exchange or sort of country visit type exercises. But coming back to Petronilla, I don't think there is a contradiction between top-down and bottom-up. I think both are really important. And we see that with the regulation in the health space. We see the same in the genomic space, where there is called the 1 million genome declaration, but it's a declaration by the member states, by the ministries, with the commitment of making data available by 2026. So that drives a lot of the policy works that is enabling. Without that top-down sort of declaration, it wouldn't happen in the first place. And then these things are hard, and we need to experiment. And I think that sort of bottom-up experimentation of the way forward is really important, to have quite a lot of different initiatives coming through, and then let the initiatives eventually learn from each other. But we really don't know what are the technologies, what are the standards, what are the hurdles we need to overcome. And so we need that sort of bottom-up innovation as well.
Enrique.
This is very true when, for example, you don't collect the data purposely for a specific research topic, but you reuse data that exists. So then you need to provide with enough use cases, so to say, of how we have reused hospital data, electronic health records data, registry data that is not linked with the electronic health record data, to solve questions that are relevant to the researcher's questions and also to policy making or to clinical decision making. So in that particular case, when you don't collect purposely the data, as in a randomized clinical trial or it's a population cohort, but you reuse, then you need, the bottom-up approach usually, because not everything fits all in the end. You need to adapt all the time. And you need to implement, and this is, I think, part of the value of PHIRI, you have to implement step by step a number of elements that assures you as researcher that the results of your research are robust enough. For example, the data quality assessment exposed. You cannot ask clinicians to collect the data for you in a way that is robust enough for you to do the research. They will collect the data and in contact with the patient in the way they used to. Then it's about you to put something in between the data and the outcome to make sure that you are not biasing your results, etc., etc., etc. So bottom-up is, as you said, Nicholas, is both things have it together.
Yes. If I may add something, I also think these two approaches need to operate in sync, and to add to what Enrique has just added, we have funded, starting from last year, a number of projects, including IDAVI. I here see Isabel de Zegger, who is with us, who actually create assistance to physicians to actually improve the quality and the representation of this data, bringing unstructured data into structured records, among others. But what I wanted to add as well is that, indeed, it is very important. It is clear, I think, at this stage that we are going to be operating in a distributed context with nodes. I think some responsibility needs to be given to these nodes as far as the curation of data and the application of the FAIR principles is put into place. Otherwise, especially when it comes to clinical data, if you look, for example, to the European Open Data Portal, which is about government data, this is what they have done. They have mandated cells in ministries with experts who have been instructed on how to work with metadata and how to make sure that it is ingestible in the Central European Portal. So this education aspect has been key to make this a reality. And of course, top-down, if you ask our projects, of course, they want guidance, fair guidance from us, or requirements. They say fair requirements imposed to us. We do kind of impose this, but relatively softly through the requirement of data management plans. Because if you see the template for Horizon, fair is the central part. But then it is up to we don't really systematically evaluate this in terms of details provided for us to understand what they do. This is what I want to add.
Yeah, so that brings in an interesting topic of ownership. And I'd like to ask the panel, where do you think this ownership should be of making sure that the data is well organized, that the data is shared, that it's findable in a way through metadata standards? How do you see this?
As I just said, I think it's a shared responsibility, if other colleagues want to add something.
I think the question is the ownership of what? There are many different components of this system, and I think there will be different bodies that need to own or govern different aspects. And you talked about banking. I often think about mobile phone. I mean, in a way, the whole mobile phone networks is really a success story of European standardization. The standards were put in place to prevent, in that case, American companies coming in and slicing the European market and forcing the national companies to pay license fees every time there was a cross-border phone call. But if you look at that, there is governance of the most critical component, which is the SIM cards, which allow you to identify the user. That's collectively governed by a GSM association. There is governance of the regulation at the European level and at the national level. And then, of course, many of the individual data is governed by laws, but we freely give that away to private companies who operate on our behalf and send the messages on our behalf. But they fall under a number of different regulations. And I think thinking about that diversity of roles and what are the different things, who govern the data, who look after the infrastructure, who look after the interfaces and the standards that makes it possible to connect, instead of thinking one big monolithic governance of everything, because that's likely to be quite complicated.
Mm-hmm. And why are we not there yet in the sector of health? What are some of the things that we think can, in the short term, improve this fairness of data and better sharing across countries? Any thoughts by any of the speakers?
It's for you.
Because it's complicated. It requires many projects, many different infrastructures on which we build with the European data space, on which we will align with. But there is no way to do it through only one initiative with one set of stakeholders. It has to build on the expertise, the experience of all of those different actors before. So it takes time. It costs money, obviously. There needs to be some guidance, be it top-down or bottom-up, but overall I think it's why doesn't it happen now? It's down to this complexity when we are seeing it.
Mm-hmm.
To me, back to the trust. To me, the focus has been put a lot in the data ownership. And this is clear. This is the patient, this is the citizen who owns the data. There is someone that takes care of the data for some users, which is take care of it, take care of the population. Then those are legitimate users of the data, of the individual data, of the personal data. Then when we move towards the secondary use, other purposes, research purposes, then we start thinking of trust in a way as if those using it were not using it properly. So a part of the fall is sort of a lack of trust in those using the data for research purposes where things have, built on in the past. So part of our work here has been this data visiting principle is so appealing because in the end, when you talk with the DPO, it's easy for him or her to understand that the data is secure. No problem with the data. We will make sure this data is personal, but it's not sensitive. So trust at this side of the different components, as Nicholas mentioned. At the other end are the outputs of the research. And open science has provided us with many instruments and many licensing types, as Creative Commons, same use, Creative Commons, non-commercial use, but open, in a way that you can reuse everything you have. So the R of the fair. If you do things reproducible in your research, then you can start with the R of reuse, otherwise not. But if you get into that, the R is quite easy in this type of projects. You are not sharing individual data, you are sharing at most, if the disclosure policy of the data holder allows you, you can provide aggregate data to other researchers. If not, you can provide with the tools to do the work. This infrastructure you've seen briefly has been seen 2,500 times by others and has been downloaded and reused by 260 already, because it's under this licensing that is reuse it. So the ownership of data, the ownership of the products, and the products should be open.
Yeah. So we talked a bit about open science and tools. I think, Nicholas, for example, in the genomics area, there are quite some tools that have been developed. So what could be efforts to continue combining this omics data with public health data?
So if we look at the, I think the difference is that a lot of the genomics tools, but also the experiences of pooling large data sets actually come from the research space. I think the amount of data that currently makes its way out of the healthcare system into research is quite limited. Most of the patient data that makes its way into research is already generated in a research context, like a large clinical trial or something like that. So it already has sort of crossed into the research barrier. But if we look at genomics, the one thing that really has driven the whole field is, of course, these very large international consortia and projects. So trying to be, and the reason for that is that you needed the numbers. You needed the power of very large cohorts to look at rare diseases or rare driver mutations in cancer. And so there was a scientific reason to pool data at a very large scale. I think the same is now happening in health. I have a couple of favorite papers I've read in the last couple of weeks coming out of the Danish system, where they look at simply at claims data, and build quite interesting AI models simply on claims data and generate biological insight from that. But the interesting part of those papers is that then they go to cohorts in other countries, in this case US or the UK Biobank, to do the same validation. And I think what we're coming to a point where there are many different types of data generated within the health system, which we need to find ways of mobilizing simply to make sure that Europe stays competitive in that advanced healthcare research space. Because if it's hard to go across countries and simply validate your findings in new cohorts, it would be very challenging to sort of be at the research frontier. And I think that's really the challenge we need to come up to. And you asked why isn't it happening? I think we can ask why. So you can turn the question around and say, well, where has it successfully happened and what were the drivers? And so if we look at the COVID vaccine certificates, that was quite easy to make those available at a European scale within a couple of months. And simply the driver was there because the risk of not making it available was actually quite massive. Your country would be outside a functioning society. You couldn't travel anymore and so on. If we look at rare diseases, a lot of data sharing happens. And that's because I think at an institutional level, you can express the risk-benefit. There is a risk of sharing the data, but actually the risk of not sharing the data is that there is a small kid in a hospital in another country that goes undiagnosed and might die. And so as an institutional lawyer, it's quite easy then to do a risk-benefit analysis and say, well, we can share this data. The same happens in cancer, where the driver, I think, is participating in the large basket trials and having access to the new medications for the patients. If you don't pool data across cancer institutes, you can't be part of the basket trials, and so your patients would get an inferior treatment. Well, then it's very easy to express a cost-benefit or the benefit of sharing the data. For many of the other use cases, I think we struggle to express that benefit. And that means that whenever institutional legal departments or deans need to make that cost-benefit analysis, they say, oh, we see all the risks, but we don't see the benefit. The benefit is a research project, but I have 1,500 research projects ongoing in my institution. I can let this one sit and wait. Mm-hmm. And so I think that's the part that we need to work on.
I mean, I agree with you, Nicholas, this idea of trying to understand what were the conditions or what was put in place when it worked. And that's really what we had in mind when we proposed European Data Space. We knew that when done right, the results had an impact on people. When new products could be developed, new policies could be better informed, that would be the driver. When we were designing, we looked at what was put in place in practice when it comes to governance, when it comes to any kind of infrastructure as well. And we discussed with those entities. We had countless meetings, for example, with colleagues of the organizations in Finland as we were drafting it. With the HDS, we didn't try to invent new concepts. We really tried to look at what worked where and what could be replicated at European level so that the benefits that derive from those individual examples could take place everywhere in Europe. That's really what we're trying to do with the European data space.
Mm-hmm. Regulation is a benefit, right?
That's where
regulation is a good benefit for an institution.
And that's where the tool that regulation is relevant.
Hannah.
Just reminding that we are always talking about health data. But when we are talking about health, it's much more than just purely health data. We need the other determinants of health as well, which will expand the problematic situation we are, because EHDS, it's only for the health data, and if we need social determinants, environmental determinants, then we are within the other frameworks again. And pulling all that together will be the next step to be able to approach the One Health, planetary health concepts within the data sharing, data use, impact of the different determinants on health of the population.
And here PHIRI plays a very big role. Can you maybe give a couple of examples, maybe from one of the use cases that have happened, or other examples to concretely show some of the value that PHIRI can provide in that?
Well, actually the use cases try to pick some salient questions on the impact of the crisis in the very aftermath of the first 2 weeks, and see how, for example, and we have Ron here, how the use of the services for COVID patients had diminished the use for other patients that needed. Urgent cases, as patients with stroke or with myocardial infarction. So, yeah, and some others, long runs as hip replacements, whether, change the trends. In other cases, whether there was another use case about delayed treatments for breast cancer women. Other use cases being about whether the COVID-19 pandemic has impacted the perinatal health indicators or maternal health indicators. Another one, whether mental health patients have been suffering further because of the pandemic and they have needed more services, or they have not been able to access the services they needed. The question is, and the line is, all these have been built upon personal data that has been made non-sensitive from many data sources. So it's not just we've collected the data specifically, purposely, as I said earlier, but we took claims data, we took electronic health records, we took electronic health records for primary care, we took prescriptions or dispensations of pharmaceuticals, different types of the social data as well. So this is one of the keys.
Yeah, thank you. And maybe one question for Jérôme. Do you see the role of research infrastructures in this changing landscape?
I mean, as I mentioned before, but also when we saw the picture from Enrique, they are complementary and really are at times inspirations, other times entities aligned with or contributing to the development and later on the operation of the European Health Data Space. So the European Health Data Space would not be able to cover all the needs, all the opportunities that can be brought by the reuse of health data. And I'm very impressed and really happy to see the exercise that you did to understand what could PHIRI be in a later stage. How could it be complementary to what will be done by the EHDS? There's a lot that the EHDS will not be able to cover. For example, support to data holders, that were some of the key aspects of the follow-ups that you will do. For PHIRI, this is something that is not foreseen. That's something we will need to rely on other European research infrastructures, other stakeholders to enable this, because this is the only way we can ensure we have the data, the right data with the best quality to support the kind of research we want to have performed in Europe.
Wonderful. I think any still burning feedback or responses? No. I think we can close here. So thank you so much for the panelists. We move on. Thank you so much for covering this topic of research. I have my mic back on. can you have I'll use this microphone. We'll continue with an intermezzo. We're going to be talking about strengthening the European health. Is very important because our workforce is the basis to be able to do all the support in health and in healthcare that we need. So we will have short pitches and front row comments on the PHIRI capacity building activities, such as the European School on Health Information, which we're very proud of, and the Public Health Foresight Studies training. So I will invite Luis Lapao and Mariana Peroteo to come and have a seat. Luis Lapao is a professor of global digital health at the University Nova de Lisboa, and the coordinator of the DISHC Digital and Smart Healthcare Laboratory in Portugal. And Mariana is a public health researcher and a PhD fellow, and her work focuses on digital health and health information systems.
Good morning, everyone. It's a pleasure to be here among the PHIRI family and friends. I'm Luis Lapão, I'm a professor of digital health, but also, very importantly here, also the head of WHO Collaborating Center for Health Workforce Policy and Planning. So I really try, and we did it very well in PHIRI, to combine the challenge of digitalization of care and the challenge of human resources. We are aware that this topic of human resources is very recent. Although we have already a good community in Europe that is looking for this, we have the observatory, we have the WHO, we have ASFER, we have other organizations that are trying to leverage what we know, what we should do in terms of healthcare. But also, we now understand that what's the shortage of skills that we have in Europe. And also that we found out during COVID-19 that there were also a big shortage of skills in terms of health information management and dealing with tools. And so we were very glad and proud that in PHIRI we managed to carry on the work we already were doing in fact, and develop very strongly efforts to develop capacity building events like trainings. Most work package managed to have seminars. We had seminars about infodemics from, we have the Spring School on Health Information that is becoming a mark. I can tell you we are going to do it again next year, focusing on preparedness and other topics. So we managed to grab the challenge of health information inequalities in Europe, because we did a survey to understand what's going on, and we managed to develop a set of capacity building events that could respond to these challenges. And I think we are hopefully publishing a paper on this soon, and of course, with your support, we are going to carry on this effort. Please, Mariana.
Thank you. I would like to share with you. So, regarding the health information portal that Hannah talked about previously, we have a capacity building section. The capacity building section on the health information portal comprises 3 pages. The first one is the home page, where it displays the highlight of the week, so the activity. Then we have the catalog, which is an inventory of all the capacity building activities regarding population health, public health, and health information. And then the agenda of the upcoming activities and events, which are activities that are organized and that will be organized during the current year. So a little bit more about the catalog. And over these 3 years, we were able to gather 191, at least until now, activities. And interesting primarily online, but we are now witnessing a shift towards more hybrid and in-person events. also, it's interesting to understand the impact that EU-funded projects and research networks have on organizing training and training public health workforce during the pandemic, such as PHIRI and other projects. Also, it's interesting to see that, most of the activities organized were within short-term activities, so seminars, webinars, and there is a preference of short-term activities because we can see there is a decrease of the organized activities when there is an increase of the workload needed to conclude the training. And just to conclude, I would like to show you this workload that are the topics addressed with these 191 activities. And I would like just to highlight the most frequent used that we can see here. That is exactly the topics that we are discussing this morning and within PHIRI. And most of these ones are, we can see that are the topics and primarily a goal of each work package within PHIRI. And it can highlight the relevance, and the goal of results that we achieved during these 3 years within PHIRI and for the sustainability and training public health workforce towards new pandemics. Thank you.
Wonderful. Thank you, Lois, and thank you, Mariana. So now I will invite Robert and Matthias to come and join us on the stage. So Robert is the director of the Association of Schools of Public Health in the European region, so ASFER, and Matthias Wismer is program manager at the European Observatory of Health Systems and Policies based in Brussels. So Robert and Matthias, thank you so much for being here. Can you reflect on this topic from your own perspective?
Thank you very much, Petronio. I'm very happy to be here. Thank you for the invite. Happy anniversary to PHIRI. We've been very pleased, from ASFER side to follow the projects and the process, like also the preceding projects, at least, from the in-fact stage, forward, and to contribute from the perspective of the community that we gather, which is the community of over 150 training sites from across the 44 countries from the wider European region that we operate within, as defined by WHO. Regarding, let me start, my reflections from indeed. As Link also, mentioned in keynote, the last couple of weeks and particularly couple of days been a lot about anniversary celebrations, and I had the luck, to actually attend the observatory event also yesterday, and I was heartened to see that, like in the Slido also, Paul, at the start, under the kind of the main theme of the event of the observatory, which was like how to harness innovation for better system performance. The second top was actually the reform of the education for health professionals, which to adapt, to new needs. And it was. Yes, it was interesting because I think, again, the PHIRI and some other projects, and I'm sure that Matthias will also reflect, and Marianne and Luis, like mentioned, certainly contribute, to this reform and, to how that reform, should take shape of and so on. From ASFER perspective, again, population health innovations, indeed, of course, like the area for the public health action, and therefore it should take, the approach of multidisciplinarity, interprofessionality and cross-sectorality. And I think, we should not forget about that once talking about the reform of health professionals, because very often, like what's needed goes beyond, the regular, the usually understood kind of a health workforce. There are a lot of other professionals who contribute and contributed, to the actions in country, particularly during the pandemic, but also what is now needed in terms of training that wider public health workforce. So we should not really, forget about the scope of the action needed here. And this is the techno that ASFER takes, as the Association of Schools of Public Health, together with partners, such as IAMFI, UFA, very much others, also Observatory, for what we call the professionalization of the public health workforce, which includes the reform of curricula, but also about the common competency framework shared across the wider public health workforce, the professional credentialing, the professional representation, and the code of ethics and professional conduct. And it is not only for bringing identification to that wider workforce, with the challenge that they face, and to position themselves more stronger in the system, the wider workforce, but also to give the assurance to the population served about the standards met and maintained by that workforce. So that is very much like what we work on. And then perhaps a couple of words more on the stage which we are at now regarding the reform of the curriculum, because that is a very current process. It will be subject to the plenary session in the upcoming European Public Health Conference in Dublin, run by the European Public Health Association. And we very much, gain from the great resources that have been delivered by PHIRI and the preceding projects, of course, as well as we connect to any other relevant initiatives, such as also relevant WHO efforts, in the infodemic management, curricula development, and some others. So this is a huge task, a huge challenge. The academic community that ASPER represents meets weekly, every Thursday morning, across the community gathered by ASPER, but also we meet globally at the so-called Global Network for Academic Public Health with ASPER-like networks from across the globe. So there's a lot happening. I encourage you, I will have to leave, for an hour after this intervention, but then I'll be back for the lunch and the networking contact. So I'll be very happy to talk to you about all more. Thanks so much. Thank you.
Thank you, Robert. Over to you, Matthias.
Thank you so much, Petronille, and thank you so much for having me. I think we cannot underestimate the importance of a project like PHIRI and Health Information Portal. We are currently engaged in 2 EU projects on the health workforce. One is the Joint Action Heroes on workforce forecasting and planning. The other is the Be Well project. It's about gaps in skills in the health workforce, digital and green skills. And in all of these projects, data plays a key role, and data is at best patchy, inaccurate, and not really timely available. So I was very happy that Dirk actually was also emphasizing again the availability of data, and that everything is actually building on data. And I think we should now use an opportunity, and some of you may seen it next week in the Gastein conference. The European Commission, we're helping them a little bit, will launch a public debate on future EU health priorities. And one of the topics they would like to see is the health workforce. And I think that what we need, certainly, is a health workforce strategy in Europe, to really understand where can Europe actually help member states, how can it advance this. I think this infrastructure is exactly one of these topics that should be included. But we also need to see that we have a European issue which is not fully addressed yet. We have a European labor market, we have mobility, but in reality, it's a black box. We are operating in the blind, again, because of the data situation. And I think here's a role, to have much more clarification on where do the people go, where do they end up, how many people are produced, and really on a very timely scale. And the other thing, I think, which is very important for the member states, which is not necessarily a European thing, is that we have much better health professional registers. I think we need actually national or federal health professional registers which include all professions, and not just the personal data, but also employment data, that we can really understand where do they work, in what settings do they work, are they working full-time or part-time. Some countries have it, but many don't have it or only have aspects of it. And if we had this data quality in countries, your network would benefit massively from it, and we would benefit massively from it, having access to it, making comparative research. And it's often very practical, actually, when it comes to health workforce forecasting and planning. It's not necessarily rocket science, but to have here really good data available would be fantastic. And I think that PHIRI is an integral part of it, and it's a great initiative. So thank you so much.
Thank you, Matthias. And maybe one thing I can add, and then you can end the panel. I think also the need for training, the need for a strong workforce is felt, I think, all over Europe. Now we have a regulation in health, which is the first regulation, the cross-border health threat regulation. And in that regulation, there is actually an article set where we will provide, or Europe will provide, a training program for prevention, preparedness and response. So I think also this is really nice to see that we on the ground obviously feel this need and are all contributing to it, but also on a top-down approach. This is the first time where we have a legislation putting this into place as well. Louis, it's your honor to close the session.
Thank you, Peter Neil, and thank you, Matthias and Robert. In fact, we did a survey to identify the needs across Europe. And that was very important because we identified the inequities. And what we saw here in PHIRI was that we managed to work together and produce capacity building activities, training that was provided to most of these communities, these countries with less capacity. So actually we managed to work together as Europe, as public health institutes for public health, and I think this is a good message for the future. We need to collaborate more in order to address this challenge. At the same time, as we were discussing 2 weeks ago in Porto, in the WHO event about digital health, we also need to think about the future of health, because digitalization of health will bring a new way of doing healthcare. And this will bring new professionals, new data specialists, and from various professions. And so the challenge is very interesting, and I hope we see some light in the next years. Thank you.
I can only second that. AI will be our next challenge and how we deal with workforce in that context. Thank you so much. So now we will have a coffee break for half an hour. Make yourself comfortable, have some drinks, and don't hesitate to chat around. See you at 11:30. Thank you so much. Okay, welcome everybody back. Thank you so much for joining us after coffee. I hope you managed to get some energy again. There were some really nice drinks, some nice snacks. So have a seat, make yourself comfortable. And yes, what we will start first with is we will highlight all our achievements, because obviously now we cherry-picked the best sections for you, but PHIRI is much more than only about the things you will hear in the main sessions. So we have also a very nice video which was developed by Barthélemy on the PHIRI achievements. So tech guys, do your magic and have the video work. I think we can applaud those who prepared this video. And then we move on to the third main topic of today, and we're going to talk about building stronger health systems, building stronger health information systems. So here we covered two important activities of PHIRI. What we did is we assessed national health information systems and the work on foresights, modeling, and scenario building. So PHIRI highlights will be introduced by Miriam and by Henk. I will already welcome you to come and have a seat. Miriam Sazo, she is a researcher and project manager at Cienzano, the Public Health Institute in Belgium, for PHIRI, and the EU Interoperability with HERA's IT platform project are some of the projects that she's working on. And then we have Henk Hilderik. He's a senior scientific advisor in population health foresight at the Dutch National Institute for Public Health and the Environment in the RIVM.
Thank you very much, Petronil. As Ninkes mentioned this morning, health information systems are the basis for the generation of knowledge to improve the health and well-being of population. However, for example, COVID-19 has put extreme pressure on our health information system because it really forced them to quickly adapt to the changing demands by, for example, creating new data flows or creating new systems and then trying to connect these different systems while still providing essential health services to the population. Alongside with the changing and evolving of the health information system, also the skills of the health workforce needs to be adapted. This is what was mentioned also by our colleagues in the previous panels, by the work done within PHIRI, but also by the work done with the observatory, with the Be Well project, and by Robert with the ASFER team. So how can countries really strengthen the health information system? Well, basically, they can perform assessment to really understand how their system currently functions. So where are the issues? Do they lie in the data collection? Are countries using a unique patient identifier? Can countries link their data to have more valuable insight? Or do they have more issues regarding like the reporting and the knowledge translation? So countries can really assess their own system to be able to understand where are the main barriers. And when assessment look at the present, like what are we doing now, and basically they want to improve for the future. But it is just one way to strengthen health information system, and there is much more innovation going on. And Hank will tell you a little bit more about this.
Yes, thank you, and good morning, everybody. Actually, the future has been mentioned, and also, if you look at evidence-informed policy making, it has been mentioned a couple of times. And there's two aspects that I want to highlight a little bit on that, I'll put emphasis on it. Policy making is about the future. We want to achieve something, we want to change something in the future. So it's also good to understand how that future might look like. Also the uncertainties that we are facing as well. The second thing is all the evidence that we generate is about the past, at best the present. It doesn't give any guarantee for the future. So we should also take into account what kind of uncertainties are we facing in the future. And foresight is methodology to get a better understanding of how that future might look like. Accounting for the uncertainties that we're facing, accounting for also, let's say, the desirable futures that we want to achieve as a society or as a Europe. So I think that is something that is can be very useful. However, if you look at public health, then the number of applications of foresight study within public health is still rather limited. It is growing, but it's limited. And then when you look at other research fields like climate change, then you can see they have built up a lot of experience that we might be able to use as well within public health. And that's something that we are trying to build up as well.
Perfect. So while we navigate through these different challenges, we also are very proud of what we were able to achieve within PHIRI. So we have performed 8 COVID-19 health information system assessment, and basically in this assessment we really investigated at all levels of a system, from data collection, analysis, reporting, knowledge translation, and governance, how the system had to be adapted to accommodate for the COVID-19 pandemic. In doing this, we interviewed more than 19 different experts that were extremely involved with the pandemic. So those were really the people that had to take decisions fast with the knowledge and the information that was available. And by doing so, we created a stronger connection between the experts in the same countries, because we brought in experts to talk from different health stakeholders in the same countries. But we also have strengthened the FHIRI network of reach of experts, so that when we need to find information, now we know better who to contact, who's really in charge of this, of managing, for example, a pandemic. Then we also train 15 different public health experts in performing health information system assessment. We talk about the importance of training, and we really believe in this. So now there are people that are able to critically assess their own health information system, but also to see other countries' health information system and see what are the weaknesses or perhaps the best practice that can be gathered from them. Then we also, to basically be able to share the knowledge that we gather during this assessment, we develop one-pagers that really summarize the funding per country on how the health information system for COVID-19 was organized and evolved in a country, but also in-depth report for the use of the stakeholders and the country, where we provided them with a SWOT analysis. So what are the strengths, the weaknesses, the opportunities and threats in this COVID-19 health information system that the countries can take up and really bring change. But we have also presented the results. So like what were the fundings that were like common across the countries? What were the most common barriers? And what were the best practices that perhaps were first developed in a country, but it could be transposed into another country? And finally, also to reach a wider audience and really to reach researchers, we're also publishing a scientific paper that summarizes these barriers that we were able to identify across the different countries. But this is just a small part of what we did within FHIRI. The work that we did in Foresight is also extremely vast, and I'll leave the floor to Hank.
Yes, also in FHIRI, we had the aim actually of strengthening the Foresight capacity within Europe. But first we needed to have an overview who is doing what in Europe. And there was a nice inventory being made by the Portuguese colleagues. And the conclusion was there is some expertise available, but it's fragmented, it's scattered across Europe, so we need to do something about that. And that's why we developed a training course, and we reached out to 70 participants across Europe to build the capacity on Foresight. And that's only one thing, to build the theoretical part, but you also have to apply it. So we also initiated and supported 11 country case studies to really see what it means like to apply Foresight expertise to a real case study. And that also, that brought to the light as well that it's not easy. You need resources to do it, but it's very, let's say, valuable as well to get the insights, what is needed, what kind of stakeholders do you want to include in your projects, for example. And also, and that's not irrelevant to mention, how to reach out to the policymakers, because it's one thing to do a Foresight study, but we want to change something. So you also have to think about what are the messages at the end you want to communicate to the policymakers. So we have developed 4 policy briefs to see how we can translate the lessons learned from COVID and the application of the studies that we did to the policymakers.
Thank you. All right, so we are very proud of what we did, but we know that this is just the first steps toward change, toward making our health information system stronger. So first of all, we have identified multiple best practices in countries, and we really want to see those transposed also in other countries, really to have these lessons learned that can benefit not only one country, but also the rest of the European country. Then, second thing, we were only able to perform 8 COVID-19 health information system assessment, but we believe it would be extremely important to have a similar exercise to really understand how your own health information system works and how it can be improved to the benefit of all the other countries that we were not able to assess. But additionally, we think that this is an exercise that should be done regularly. So every few years, a country should critically assess how is the the health information system changing? How, which changes have we witnessed from the last assessment? Were like steps taken forward to actually improve the health information system of the country, or do we need to make a new plan to really bring change? And finally, we really see how by doing this assessment, you create collaboration. COVID has been an extreme good example of this, how this health stakeholders really had to come together to make decisions how to best tackle the pandemic. You also see this happening when you perform assessments. And I'll give the floor to Hank.
Okay, thank you, Miriam. And also regarding foresight, it's rather clear. We have to strengthen foresight capacity in Europe to be able to set the next steps. And that also means that we have to include relevant data information in health information systems. For example, to have a better understanding of trends, not in a country only, but also across countries, that we can compare them. And the third point, the link to policy making is crucial. That's where maybe let's say the money might be, but also that's where we want to make a change. And my institute, RIVM, is already working for more than 30 years on public health foresight, and we know how difficult this is. So that is something I think we should also invest in further in knowledge translation. And the last point that I'm always trying to make is not only evidence-informed policy making, but also including the uncertainties that we have in the future. So I refer to that as more or less foresight-informed policy making. Thank you.
Thank you, Miriam and Henk. So next we have another Slido for you. So in this Slido, we wanted to ask you which area in health information systems need the most strengthening. So I think you remember the slide from Nink at the start, where we had how a health information system is composed, going from data information, knowledge to wisdom, and the several elements: data collection, analysis, reporting, and policy making with the underlying resources that are needed for that. So our question to you is, which area do you think needs most strengthening? So while these questions are coming in, you can keep this on the slide. I will start welcoming our next panelist. We're very honored to have here Bruno Ciancio. He's the head of surveillance section at the European Center for Disease Prevention and Control. Then we have Dimitra Pantelli. She leads the work on implementing innovation at the European Observatory on Health Systems and Policies. Have a seat. We have Eric Sutherland. He's senior health economist leading the Organization for Economic Cooperation and Development work in digital health, so from the OECD. And we have Maria Daniel Loureiro. She's an intelligence analyst at the Intelligence Gathering, Analysis and Innovation Unit of DG HERA at the European Commission. So welcome all four of you. So actually maybe we can reflect on this first. Do any of you have any thoughts when you see this coming up as the areas that needs most strengthening?
Yeah, thank you very much. Maybe I can start. I'm Bruno Ciancio from ECDC. Yeah, I actually voted governance first too. And the reason is that we know that there is wealth of data in the countries, in Europe and outside Europe. But what we lack is really a public health driven governance. So what are the key roles that need to be played when it comes to answering the key public health questions? I think in the past, public health has been quite shy in showing the leadership in this field. And I think it's now time to maybe use the momentum of COVID, the importance that was given to public health to build up a more general data governance for public health.
Thank you. And if I may build on that, I think it's also the foundation for all of the other options. I think if we look at that more closely, I think this is how we build the rest. I voted for knowledge translation. It's mostly because of my job, because this is what we do. So I thought I don't want to lose my job, so I better vote for that. But maybe when we continue, I can reflect a little bit more on that.
I also voted for knowledge translation. I think on our daily activities, one of the most evident things is that there is a lot of knowledge being generated at clinical hospital level, a lot of knowledge being generated in academia, and it's not that often that is translated into decision making and policy making. So I think knowledge translation is really the best way to leverage the data that is already being collected and analyzed, and the insights that are being generated in these fields, in academia, in the clinical world, into policy making.
So we're definitely, yeah. So we're definitely bookending because I voted for governance first. Also because the OECD published its guidance in health data governance, so it seemed appropriate somehow. But practically speaking, it's actually very much referring to what you were saying. It's the foundation of everything. You don't know what data knowledge translation needs to get done unless you're actually overseeing the system. So it's not governance to to hammer people, this is what's going on. It's to actually provide oversight of the system, see where the problems are, and ensure that investments are actually being done that actually achieve the outcomes you want and are reusing things. So if you actually want to drive the FAIR principles, governance is a core part of it.
Just wait. We'll put it on, I think. I can follow up on this? Okay, yeah. I couldn't vote because I didn't bring my phone up here, but I can understand the results. And I would also like to comment on governance, because what we saw in our assessment was that most countries, for example, were lacking a pandemic preparedness plan, but we saw that the ones that had it, they were really benefiting on having some guidance on how to take action. And when a strong pandemic preparedness plans was not in place, then in certain countries we saw that a management team was set up, and really the responsibility was to take decision on how to organize things, but not having a structure to fall back to that give you some structure on how to act really caused a lot of miscommunication within the country. So there was a lot of duplication of work, and the responsibility, who is responsible for what within a health information system, especially within a crisis, this was really missing. And it's something that I'm sure we would need to work more, and I know countries now are taking concrete action towards strengthening their pandemic preparedness plans.
I already stated what I was. I hope I didn't influence you, but it is about knowledge translation, I think, and it's not only thinking that we have the knowledge and we have to put that on the plate of the policymakers, we also have to critically consider, are we gathering the right information, the right knowledge actually that policymakers are needing. So it's not only one way, it's two ways.
So now we're really interested to hear from our panelists if you could share your experience with European health information system strengthening through your work and health system strengthening. What are the areas that you're focusing on? Because obviously resources are always limited, so we need to prioritize. Would love to hear from you.
Mix things up. While I'm at the OECD, I've only been at the OECD for 10 months. And so I'm still learning about Europe. I know historically when we published our report last year looking at health data governance practices in Europe, the leading countries were, no surprise, Denmark, Finland. But there was a very wide range across all the countries globally. The OECD has 38 members. And so in that perspective, we see there is significant work that needs to happen in order to strengthen our health data governance practices. One area that has been iterated to me the most, however, in Europe, and I apologize for the following phrase, but it's something that's been said to me many times, is the data prevention officers. Sorry, data protection officers. And when I was at a conference in Germany, they were very poignant saying, like, are we protecting the data or are we meant to protect citizens? That was very poignant to me. Are we trying to mitigate privacy risk or are we trying to mitigate harms? And actually, Nicholas mentioned it before about the use case of, well, if we share the data, can we actually save a life in another country? Frankly, by one of my colleagues in Canada, he sadly says, he's an ER doc in the northern part of Canada, and he has killed patients literally. He has killed patients because he did not have the information he needed in order to actually provide care. He did not know this person had been in the hospital 2 days earlier and had had a procedure. So that's a failure of governance. That's a failure of actually sharing it. And it's recognizing, yes, there is privacy harm. There's 9 other possible data-related harms. All of them need to be considered in doing it. And that's one of the things that I'm personally starting to get a little obsessed by, because I think from a European perspective, I think it's going to be significant importance going forward, especially for the AHDS.
Maria, what are you focusing on?
So at DG HERA, particularly my unit, I'm in the unit for intelligence gathering, analysis and innovation. What we've been looking at is trying to find ways to leverage data to improve Europe's ability to detect, well, prevent, detect, and respond to serious cross-border threats to health. And we try to do this by ensuring that medical countermeasures are being developed, manufactured, that the procurement mechanisms are in place, and that supply chains are also in place. And through our work, we have been finding out that the most efficient and probably the only way of doing this is to leverage the data and the information that is already being collected by EU agencies, member states, also open source intelligence, information by the WHO, etc. So right now at HERA, what we have been doing is setting up an IT system called Athena. It's something that we're working on, which will help us assess these health threats and also prepare options for response, for policy making, and also try to map these supply chains of medical countermeasures, critical medical countermeasures, in order to respond to these health threats. So we are trying to improve, to help, to use IT systems to improve our response mechanisms and try to leverage this data that is already there and being used for other ends, and they're trying to reuse it and to leverage it to try to improve the response mechanisms to cross-border threats to health. Yeah.
Thank you, Dimitra.
Thank you. I think these are two slightly separate and complementary questions for me, like strengthening health information systems and strengthening health systems. I think primarily strengthening health information systems is a prerequisite for actually strengthening health systems. We at the observatory, we are knowledge brokers, music to our ears, that one of the main goals of FHIRI is also getting to understand how data or evidence can speak to policy. This is exactly what we've been trying to do for 25 years, as we've heard many times today. And I think often the intelligence that we use is a slightly different type of intelligence from what we saw here. So it might not be quantitative data, it might be more qualitative data from talking to policymakers in different countries. But what we always try to do is we feed back when there is no availability of good data, that we lack the information on this. So this perhaps closes the circle from this effort to strengthen health systems towards strengthening health information systems, because we try to pinpoint where we don't have the information. One example that I'd like to mention on making data speak to policy and how we do that is actually the efforts that we're doing together with the OECD and the European Commission on the state of health in the EU, where you see that there is a lot of effort going into how do we visualize the key indicators for health status, for health expenditures, for workforce, in a way that will actually come across, and how do we distill information about a health system that is pertinent in 10 pages, basically, so that policymakers will read it. And I think these are approaches that have taken time, they've taken a lot of expertise from many different people. We have several streams, so I could go on, but I'll stick to that one. And I think in that sense, it's really something that could be helpful for FHIRI, that we can share our experience from this. And I think when I look at what you have achieved and how that could be helpful for what we do, because a lot of what we do is very rapid response to needs in different countries or at the European level. And often, if we had readily available evidence, we would be much better able to respond. So I think this, what we saw, is really a game changer for us as well. I stop here and then I...
Thank you. Thank you for that question. I mean, at TCDC, the main focus now is trying to address some of the shortcomings in the surveillance systems observed during the COVID pandemic. So we are focusing a lot in strengthening the resilience, timeliness, and relevance of surveillance data. And we do this in various ways. We're trying to support member states in using data from electronic health records, developing an interoperability, as we learned in the previous session, is still far away. But what we are trying to achieve is objective-driven interoperability. So try to tell member states, these are the type of questions that we need to answer. Let's try to extract the data in a comparable way across the countries. And this is where also the work of PHIRI becomes very relevant, and that we should actually work more closely together in the future. We are also working on trying to bridge significant differences between countries in the level of performance of their surveillance infrastructures. Macrobiology is one area that was really very differently distributed, competencies and infrastructure very differently distributed. So we invested a lot in strengthening laboratory capacity and providing training in bioinformatics. We are participating to the European Health Data Space, although this is going too slowly, and here is where maybe a top-down approach would help. For example, with a more concrete political will from the member states to adopt the regulation, which is there for quite some time now. In addition to this, we are trying to strengthen surveillance capacity around the European Union, working closely with Western Balkan countries, with African CDC, and all the countries in the Mediterranean region.
Yeah, thank you. I think that really nicely brings us to the next question we have prepared. Is we were thinking, and Miriam can maybe illustrate, we saw quite some differences between countries where their strengths and their weaknesses lie. So when in your organizations you have a more European approach, all four of you, how do you address that? How do you take that into account when you are preparing these programs, when you're carrying out your activities, to really make sure, you know, that we bring up the level in the same way, but ensuring that everybody can, you know, learn from each other and reach the same level?
Maybe I start now and we go back there, because it's so much close to what I was telling before. You all remember when COVID started and ECDC was kind of criticized for not saying actually very clearly what we were recommending to the countries. And of course there is a reason for that, because member states are very different and we need our recommendations to fit basically all member states, to be relevant for all. So the mechanism that we have in place for achieving this type of relevance and applicability of recommendation is to intensify the collaboration. We consult with our member states regularly. We let them validate our recommendations, but this is not enough. Where we need to go now is more to access data, what I call contextual data. So we need to understand actually how the recommendation are feasible at the local level, taking into account the vulnerabilities of the populations, the risk factors, the performance of the healthcare systems, the level of utilization of the healthcare system. And in addition to this, you need to be able to health system to generate the data that are necessary for prevention. So we need to invest more in evaluating the impact of prevention measures and give feedback to the population on how preventive measures are working. And I think these are the key gaps that we need to address. And I'm really open to expand collaboration with CDC, not only with the usual stakeholders, but also with some of the stakeholders in this panel today.
We go in sequence again? Okay.
Go ahead. We're having a good flow now, so let's keep the sequence going.
Yes, very good. So the hashtag for the 25th anniversary of the observatory was learning from each other. And so I think this is one of the key components of what we do. This is knowledge exchange and facilitating knowledge transfer, which isn't always easy, and sometimes it isn't even possible. What we try, and this is part of our expertise. I think one thing to be aware of, and that we profit greatly from, is the observatory is a partnership hosted by WHO, the Regional Office for Europe, which means 53 countries, much more variable than the EU countries if we only look at the EU. But this is our hosting partner, but we have a number of other partners who all sit on our steering committee, 10 member states, a payer, research institutions, and they all help us shape our work and how we go about it. So it is, in a way, really crucial that we have around the table people from different settings so that they can help us tailor our work so that it reflects both the needs at the country level, but also the potential for international action and international collaboration. Matthias mentioned before that we are now embarking on this journey of thinking together with a range of stakeholders about the new priorities for the next Commission. And so that, I think, also will entail heavily thinking about where we can help at the member state level and where we can help at the European level. Perhaps on the observatory side, on the operational side of what we do, we have some activities that are more targeted to individual countries where we get asked to provide support. We bring expertise from other countries where it is appropriate, but it's tailored to the one member state or to the one country. But we also have a range of activities where we try really to generalize our findings and the options in our analytical priorities, for example, so that we can benefit decision makers in different settings. It's not easy, and I think with PHIRI you see that we have such a different and varied environment. It's not necessarily always possible to have one recommendation for everyone, but I think that's another crucial part of this knowledge translation, which is the tailoring of the solutions to the setting and then figuring out the balance of getting the setting to match or to catch up as much as possible, but always mindful of the particularities of the specific place. So I think this is something.
Maybe before I go to Miriam, can you maybe illustrate how the recommendations that we looked at and the gaps that we found when we did this assessments in countries can complement this type of approach?
Yeah, so actually of the points that you have already mentioned, I'd really like this one of the aspects of the observatory that you say learning from each other, because in our exercise we really try to make understand the country, how it was important to have the country assessed, but also to be actively involved in the assessment of another country. So basically we would have different contact person in the country, and we would we would support them throughout the way to go through these expert interviews, assessments, so they could really see, having the expertise in their own country, okay, in this other country, those were the issues that were faced, but those were the innovation they have implemented. Can we perhaps do this? So we were really strengthening the capacity, but also the awareness of how other countries were working and how much they could learn on how another system was organized. Then I think another point that Eric mentioned was before about data sharing, and we saw issues both within the country. So we really saw how the digitalization, for example, of health system changes a lot in countries, and how this caused harm to the patient within country, just like talking region to region, like getting care in one region and not in another. And then of course this issue of sharing information also on across countries, that it's one of the main pillars of PHIRI that Enrique and Hannah have illustrated a lot about interoperability and the work that we are doing at the moment.
And do you maybe want to bring in some of the foresight experience in this?
Yes, and actually it's also something that we, maybe to make it a bit more complicated as well, but Dimitra was pointing it, I think, very nicely, that we should also be open and not focus on only things that we are measuring already, that we are bringing across, but also not everything that is relevant is measured already. Just to bring an example to the table, we have had an enormous focus on cardiovascular diseases and cancer with the risk factors, and we have an enormous amount of evidence how they are linked. However, what you can see now with mental health, we are lagging behind, I think, miles and miles. So we really have to catch up, and if we had applied foresight at an earlier stage, and we signaled that already, then we might have now a better clue how to deal with mental health and the risk factors of mental health. Also guiding countries more, what should we measure? What data should we collect regarding mental health? To be honest, we hardly have a clue. So, not to make it very complicated, but I want to make it more relevant.
Maria, Eric, Dimitra, do you want to go? Maria?
So at DG HERA, one of the projects that we currently have that I think, Miriam, you're working on the EU HIP, the EU HIP project. Basically, from our experience working with member states and the experience consulting member states now for the development of Athena, what we realized is exactly what Bruno was saying before, that there's a lot of heterogeneity at member state level in terms of what variables are being collected, in what format, with what frequency, what's the level of granularity. So this was obviously an issue that we already had foreseen, but not with the intensity that we encountered it. So we set up an action called UHIP, which is the interoperability with HERA's IT platform project, where the participating countries are encouraged to collaborate in an efficient manner to improve their IT systems and to make them interoperable with Athena. And here we're talking about early warning and response systems, pandemic intelligence systems, systems for tracking of stockpiles of specific medicines. And this is a project that has been going on with so far very early results, but it's one of the measures that we put in place to try to in a way mitigate this issue. But I have to say that I really agree with what Bruno was saying before. You can promote cooperation as much as you want at member state level, but in the end there comes a point where you really need a top-down approach with some guidance on what variables need to be collected, what systems need to be built. I think we see a lot of effort from member states, I say it again, from academia, from the healthcare sector, in trying to produce content to be used for policy making, but then the circle of feedback from policy making back to member states in terms of what we need, this circle is maybe not closed. So this is something that hopefully with the experience, obviously HERA is a very young institution, but I hope that with the experience we can also contribute to closing this feedback loop and to improving intelligence at member state level on what is useful for policy making.
That was a heck of a good setup. So one of the other things, reflecting on what we've been talking about, we've heard a lot about top-down, bottom-up over the span of the day. And where top-down and bottom-up meet is in the realm of policy. And that realm of policy, it's not like just the strategic policies, it's the operational policies that includes things like what standards you're actually having, who's accountable for setting those standards, how do you measure their effectiveness. It also includes things like what your privacy and access policies are, de-identification policies, what are your policies around the workforce. So one of the things that we'll actually, the OECD will be publishing later on this year, we have our annual or biannual Health at a Glance paper. This year's thematic chapter in Health at a Glance is on digital health. But the lesson from the chapter is, you know, countries really aren't that ready to go into digital health, and we don't really have good measures anyway of what being ready for digital health is. And so in response to that, what I've actually been doing, which I think is largely reflective of the type of things we've been hearing here today, is I've been developing like what is a checklist of policies? What are the attributes of policies that need to exist for countries to operate within the country and for countries to operate across borders. Because it's partly a reflection that few countries are monolithic, as in like there's one authority that dictates them all. Often countries have 3, 4, 20, 50 different regions and sub-regions within the country. And so the policies that exist in those countries, there's often resistance toward top-down edicts about this is what the federal government wants. It's like, yeah, it's great, but in our region, we're going to do it our own way, as long as we're substantively similar to what the federal government is doing. I come from Canada. I know all about it. And so a big problem that we have there is how do you harmonize policies across borders, which is to say, what are the policies that are most useful from the perspective of driving better use of data, better collection of data, better access to data, better use of data for knowledge and insights and action. And based on that, how do we actually ensure that the policies exist across borders, and how do we create the incentives for things across borders in order to achieve those outcomes? And that's why, as I said at the outset, that's why I rated governance #1.
Thank you, Eric. We'll go to Dimitri straight away, but I just want to mention if there's any questions in the crowd, please just raise your hands and I will give you the floor. Dimitri.
Thank you. Perhaps just to build on what Maria and Eric were talking about, and just how to get the right infrastructure, how to get the right data available. One of the areas that we work on is health system performance assessment. So if we take that maybe a step further onto then what type of data do we need content-wise to inform how we shape our health systems. I was really emotional seeing the Bridge Health logo there before, because I remember being in that project while I was still at the university in Berlin. And I don't remember the number of indicators that we collected in the end, but it was definitely 3 digits, and it's not an easy process. And for us, what we realize is that sometimes, especially for policymakers, it can be quite difficult to advocate for 350 indicators that are routinely collected, routinely reported on, routinely considered when you do policy. So what we're trying to do at the moment is to try and create some sort of short list of, like, let's say, these are the 5 things you need to look at if you want to know about the state of digitalization in your health system, or these are the 5 things. So, and it's a process, but one of the things, the very interesting things that keeps coming up in our discussions is, but will all the countries have this data? And the answer is always no. And we have different countries where we know that we have quite a lot. We have different surveys or different sources that we can draw on for that. But the result is a mosaic. And then we have realized that this perhaps will be one of the main contributions of this thing, that then decision makers will realize, wait, we actually should probably be collecting this because we can't have, we don't have an answer. And to just leverage the mechanism of that Eric used, he's from Canada, he knows all about it. I'm from Greece originally, so I know all about trying to find information on something and not finding it. So I think this will be quite a strong way to move this forward.
And I think it's not only a question, do you have this data now, but these things also change over time. We saw during COVID a lot of data collection systems were set up or altered or changed, and now they're changing again because of the priority that there is. So my question then to you is, we all work in health. How can we keep, this attention on all these important elements that we have mentioned already now in this panel, to keep on actually investing in this, to be able to continue, improving and finding also among all of us sitting here the means to be able to continue paying attention to this now that the heat of COVID has passed?
Wow.
Hard question.
I think there is a lot that has to do with building a wider public health culture also in the population. There has been a lot of misinformation and also mistrust, and also when it comes to the secondary use of health data, this is not intended for what it should be. Secondary use and public health use essentially means large-scale individual protection, and this step needs to be guided by public health authorities. So this is one way. Another is really not to abandon what we have developed during COVID. Many countries have developed targeted but also time-limited legislation when COVID came in terms of data sharing, and now they're coming back to the status quo that was before. This is a big mistake. We need to build on what was developed. For example, centralized sharing of laboratory results was fantastic. During COVID, everyone could provide daily data centrally, and this data were shared at European level. Why don't we build on that? I mean, that is so cost effective instead of implementing new infrastructure just to reuse what was done during COVID. And I think we need economists here to show also that this is cost effective. What are the most effective choices that governments need to do to ensure protection of our populations in the long term?
Yeah, it's incredible what kind of things can happen in times of crisis, right? Dimitra, do you want to add? And then there is a question from the public. Dimitra, go ahead.
Yeah, I'm just going to go at the very macro level and say, I think we see a shift in the way that we've been thinking about how we make the case for health. And Matthias, I think you would be better placed to talk about this than I am, but this whole idea of health in all policies has been evolving into the idea of health for all policies, and basically making clear again and again that investing in health is an investment in well-being, that this is not necessarily costs, but it's actually investment. And I think at the policy level, this is what we have to do. How we then make sure that we allocate the right amounts of funding to different streams that actually serve the purpose that we're talking about here is a slightly different question. But I think at least at the political level, this is where we need to be.
Eric.
So taking the economic challenge, thank you. One of my fundamental beliefs, and one of the things that I think we need to talk about, are two unique attributes around the data in of itself, and we need to be advocating to our policymakers, including our ministries of finance, not health, finance, that the value of the data is actually really important to unlock. Data are the only asset that will consistently appreciate in value over time. Every other asset, your technologies, sadly, your people, your bricks and mortar hospitals will always need repair, they will always need fixing, or they will retire. And so where data, when you have the data there and it's curated, you can link new data, you can answer new questions that you didn't have before. And so you actually can create better systems, and it's the only way to meaningfully bend the cost curve of the system is through investments in our data infrastructure. I would like just one last point that my definition of resilient health systems are systems that are able to answer novel and new questions. Answering novel and new questions requires access to data and the ability to add new data when you need to. And so really it all comes down to the data.
I think you're preaching to the converted, we all agree. A question from the crowd. Please introduce yourself and ask your question. Thank you.
Good morning. I'm Pascal Derek, working for the PHIRI project. I would like to come back to the achievements. We have built a framework for federated analysis. So we started from the data to create some indicators. And the baseline for this conference this morning is from data to public health actions. If I reverse this baseline saying from public health to data, how do you see to having this framework in place for the federated analysis framework, this potential research infrastructure in place for the long term? How do you see as policy makers looking at the governance, how do you sustain for the long term such an infrastructure, having a federated analysis framework in place? How do you see this? Just changing the baseline from public health to data, because as you said, Eric, we can also customize the data to be ready for actionable for the next pandemic, for instance. Thank you.
Do you mean sustain the infrastructure in terms of financial resources, for example, or in terms of evolution of content? Just in terms of understanding the question.
It's a methodology. It's experts that you have to bring. You have to keep operational a methodology, a framework. So it's about technique. It's about having infrastructure ready with the right data, so that everything is actionable at the moment you need it. It's a question of governance. And here, with the PHIRI, it was a nice exercise to see what was needed in terms of being able to bring public health responses, knowledge translation. We need indicators. How do you create this kind of indicators using this type of methodology? All this aspect of operational data flow and involving experts, but also technology. How do you see this at the level of governance?
Difficult question, lots of thinking. Any responses? Any thoughts? Go for it, go.
Yeah, no, it's very relevant, but it's also a question for you, actually, because you have done so much in PHIRI. We need now to operationalize. We need to come up with quite a few compelling public health questions and try to see how the data can be used to answer those questions. And this is the last step, which I think it's very much overlooked. When we talk about data quality, often we focus on maybe completeness, coding of certain information in different ways, but we need to bring this to another level of quality, which is more epidemiologically driven. And I've not heard enough in terms of embedding research studies which really take into account all the quality requirements for providing solid evidence for decision making. We need to work together, the epidemiologists and the data providers, and come up with these use cases.
Thank you. And any final? Yeah, go ahead, Dimitri, and that will be the last.
Maybe, I think that would have been my reflex as well, to maybe pass the question back to you, but in a slightly different way, in the sense that my feeling is this is about, we did so much good with this on a project basis, and how do we make sure this is actually then continued, it doesn't stop here, right? And I think this is perhaps a question for colleagues who are here from the Commission, or colleagues who are here from national funders or national decision makers. My feeling would be, we just really need to make clear, as we were hearing before, why this works and why this is important, and really invest in making the case for, look at this, what this can actually help you with, look at how we can use this data, and it doesn't have to be COVID-19. It doesn't have to be a crisis of such an urgency. If we can really show, look at in your regular decision-making cycles, this is where it comes in. I think that's probably one, or the main way to actually make the case.
Maria, Eric, any final thoughts that you would like to share? Yes? No? Yeah, but I think, Ninka, I look at you. We move on. Okay, let's go for another question.
I'll try to go fast. Isabelle de Ziger. I'm the clinical coordinator of a project ADAVA in Horizon Europe, but also, and as the reason of my question, I've been the leader of a think tank of citizens during the pandemics, trying to figure out what to do with all those different guidelines across Europe. And so I think there's obviously a huge problem with data. I think there is another problem, which is more in the hands of the policymaker, which is to make the guideline more understandable. And first, to align them. And maybe there's something that I think has been completely unused and is a low-hanging fruit, is a recommendation by the OECD to have rules as a code. So at least you will be able to start to formalize your policy in some shape or form, and be able to reason in a much more effective way than talking about it. They have a lot of meetings because it's difficult to compare them. So Eric, the question is probably more focused to you. What is happening with that recommendation by the OECD of making all those guidelines formalized so that they can be reasoned upon? And that it is in your camp, while data is probably more difficult.
Thank you. No, honestly, thank you. I would say the I'm actively trying the work I'm doing to recognize that data are not enough of the solution for where we need to be going. We need to bring in, we've already heard the specter of AI once earlier on this morning. Where is that going? How does it feed into our data governance and data management practices? What is the technology we need to have in place? What are the human factors that need to be guiding the thing? And how do we ensure that our workforces, and by the way, I don't actually mean health workforces, I mean the digital workforce that supports the health system, because we don't know how many people we have as technologists and as data stewards and as data managers in our system. And because we don't have that, we don't know what the value of those people are. And so I think we need to start thinking about that. In terms of, we actually have a health ministerial meeting in January. I'm making sure that data is on the agenda. It is something that's very near and dear, but that's actually part of the reason why I was putting together that policy checklist. I've actually turned it into a readiness assessment tool, hence why I want to talk. And because I think that starting to roll that out across countries to say this is what good looks like to harmonize people, I think is really important.
All right, thank you so much. So a big round of applause for our panelists. Thank you so much. I will ask you to get a seat again, and then we'll move on to our last session. So our last session is about building collective intelligence. We're going to be talking about PHIRI's Rapid Exchange Forum. Building collective intelligence, the Rapid Exchange Forum of PHIRI will showcase the experience that we've had with this Rapid Exchange Forum and how it allows to provide a forum, a rapid exchange mechanism of information across countries. So we already talked about sharing between countries during the crisis, but also in peacetime and beyond. So now I'm welcoming Claudia Habel. She's working in the field of healthcare, and she's currently at the Austrian National Public Health Institute, the Gesundheit Österreich, in Austria. And here I will pass you the clicker, and the floor is yours, Claudia. Thank you.
I think I have only this slide, so it's quite easy. I don't need the clicker. I'm so pleased that I'm here, you know, and you heard a lot about PHIRI, and I think the Rapid Exchange Forum, okay, also because we led this work package, but still it represents the heart and soul of it, I think, because all the information you see that we generated, everything that we needed for decision making, everything was discussed here, you know. In the end, you see we have figures that we had altogether 67 meetings, because actually we started immediately when the crisis hit us. It was also one of the reasons why we started loosely to have a sort of exchange. I think Commissioner addressed Sansano that we have this exchange. I also want to mention a guy who was not mentioned before. It was Herman van Ooyen who started this undertaking. I was hoping he is here today, but he's not. But he was also very eager and behind that we, Petronile and also now Nienke, that we could have this exchange together. What we tried, I think what's special, that we really tried to bring things together, you know, sound evidence for decision making. We had really a very high level of expertise. We had a list of experts. I see Neville will speak later from Malta. He also grabbed around in his telephone book, I think, and made a lot of renowned experts sharing information with us very quickly. We had really what I liked so much. You know, I'm not the scientific person number uno, despite we got funding luckily from DGRTD and through the Horizon program. It is very hands-on and practical. This is what we needed at that time. People like myself, our boss was one of the crisis, I would say the advisors to the minister on this crisis. And a lot of people in our group had this role or were acquainted to such crisis response teams. So we had, for instance, I think good examples were in cooperation with other partners. I think the Prepare cluster was mentioned, for instance, but also with ECDC. You know, we had a very good cooperation with them, or also with the Health Security Committee, you know, which is the high-level people, or it was the ministries discussed the responses. But we were a bit, let's say, 2 weeks before the official meetings, so we were asked for advice.
Okay, do we need to spray infect all the streets? I know this is my old example, but still I think it's a good example. Taiwan and China and others started to spray infect all the roads and every buildings. We saw the pictures. Really, people were asking ministries, and there was newspaper alerts, why isn't Europe doing that? And actually, we didn't have all the machines, so there was plans. Do we need to have snow plugs? Or, you know, those water throwing machines from police? Rechanged, rebuilt to do also these spray infections, and very soon we realized, no, it's more an airborne disease, so we perhaps don't need that. So everybody saved a lot of money. Who said that it was very cost effective, can I say so? Because we had this decision, we found some expertise on it and evidence, and we brought it to the Health Security Committee, and so people knew about it. And the debate was really quick, I heard. I think this is a very good example what we achieved. And what's also very important when we talk about data, but still, and also you have data analysis, but sometimes there are the nuances, and you would like to double check before you present something to your minister, and you know millions of euros will depend on this decision. I really prefer to double check with my fellow colleagues in other countries. Do you have the same opinion? Yeah? And because it's very likely that the minister asks their fellow country ministers, do you have the same ideas? So it's always good. And finally, we also had, of course, some moral, I don't say shoulders to cry on, but like moral support, I think, was also there. So we had the same challenges, the same experiences. We had a lot of online meetings, of course, so we saw the kids and dogs of people jumping in the rooms because everybody was in lockdown. You know, so this, I think, is also a secret of success. And I think the Rapid Exchange Forum as such is a very, documented format also. If you would like to do me a favor, go to the Health Information Portal after this meeting. Yeah, if you haven't done so, please do now. It's really a very valuable resource. We have a Corona corner there. Everything we did is reported there. You can read it, you can do further analysis. We had also a measures page, a very general one, which was very often consulted. And as we were asked always for sustainability, this is still there. You know, it will not stop. We will try to maintain the meetings, perhaps not on a bi-weekly basis, but monthly, perhaps not with 25 attendees, but 15. But the infrastructure will be there and can be used for any type of crisis in future as well. That's it.
Thank you so much, Claudia. So also here we have some front row comments. I will invite Jurje Stassens. He's the head of the Crisis Coordination and Strategy at Cienzano in Belgium and the coordinator of the Belgian Risk Assessment Group to come and join us. And I also invite Nevel Kaleya. He's the director of the Department of Health Information and Research at the Ministry of Health in Malta. And he's the head of the Department of Public Health at the University of Malta. So you both colleagues shared your experience, used the Rapid Exchange Forum. Can you maybe share some of your experience of making use of it, both maybe at both ends, depending on who the question is related to, but you provided also answers to some of the questions that were circulated, but you also asked questions, so it would be lovely to hear from you on that. Jurgen, would you like to start?
Okay, well, thanks first of all for inviting me. I'll give the perspective of the crisis management and preparedness as well. So I can only confirm what was said about this Rapid Exchange Forum. I think it has an added value during crisis, preparedness. Maybe I'll think about potential as well later, but we had some very nice examples where this Rapid Exchange Forum helped us really in decision making or to help decision makers to decide. One concrete example is that we had over the past few months, last year, lots of discussions in Belgium about the barometer, the famous barometer to monitor the epidemiological situation on COVID. Other countries had different experiences, and we were thinking about what would be now the future of this barometer. Do we need to develop something else, something more, nothing at all? What are other countries doing actually to monitor COVID or respiratory infections? And I think maybe before PHIRI we would have called a colleague in Holland or check a website or Google whatever to find out what are other countries doing. And well, there is this kind of an informal network. Everybody knows somebody. But I think the advantage of this forum is that there is now a structured forum. So you don't have to call somebody anymore. You launch the question. and you get an answer. And for this specific question of the barometer, or we call it now the respirator, we really had a fast answer from 10, 12 countries, I think. And it really helped us to say, look, this is what those countries are doing. We can use those experiences or not. And it really helped us to develop our own new respirator tool. So I think it's really a nice example of how this rapid exchange forum rapidly actually gave feedback. So.
Thank you so much, Jürgen. Neville, would you like to share from your experience?
Yes, indeed. I think one of the questions that possibly some of us are asking, like, but do we really need another European forum? Like, don't we have enough? And the answer is, in this case, yes. Because what we were getting, as Jürgen was saying, were sort of this informal initial feedback, immediately, urgently, to address your concern. And it's the kind of feedback that countries were not willing to exchange officially in official fora, because there would be the political layer that filters out certain information. So this was critical. This was a group of friends, readily available, on tap. And credit to GUG, actually, also with the reporting structure, because not everyone was getting the same burning question at the same time. So maybe I'll get it 2 weeks later. And the knee-jerk reaction would be, we also had sort of this ad hoc asking of questions, so to say. So we don't wait for the meeting. It's too urgent. I need an answer for my minister, next Monday. And we send out an email to everyone. So instead of doing so, we can also check the reporting, because maybe it was discussed a couple of weeks earlier. So this was critical. It's the informal nature of the exchange of information. And this morning it was fantastic listening to Dirk. It feels so familiar. I think maybe the observatory should think about getting some of us together, recounting these stories of how we procured drugs and stuff and PPEs and how we got scammed. Anyway, that's for another day. But this is the whole point, the informal nature of it, I think. And again, coming back to the point that Claudia raised, I think we've also saved money through the REF. Because, even with drugs, like, you hear about a drug, like, guys, I hear the Italians are buying azithromycin. Should we try to get some? This was how it was working. And through these fora, we could actually discuss in a proper way as to sort of what is the experience out there, the unpublished experience. And I think this was critical.
Thank you. All right, so we're slightly running out of time, so thank you so much, all three. Round of applause for our panelists. So COVID has not completely disappeared. Unfortunately, our project officer, Andreas Holtel, is at home in quarantine because his wife has COVID and he's coughing. But we have wonderful replacements. So Jana will fill the spot for us, or for him. She will share some kind words with us. Thank you.
Good afternoon again. I am very pleased to deliver to you a message from Andreas Holtel, who is the project manager, the project officer of PHIRI, which is quite personalized. So I decided to read it to you because it contains very interesting and inspiring elements, I find. So here we are after 3 years of PHIRI. And you did it. A fully fledged European health information portal is in place, and important data infrastructure elements have been built that are already in high demand and in other pertinent contexts and projects like the European Health Data Space, the Horizon project by COVID, and others. Thank you for your great and dedicated work. It has been an honor to act as project officer for this project, and it was very easy for me. The management of your project has been excellent, trust-based, very interactive and transparent, exceptionally smooth, not a single amendment, not even an extension request, which I'm also very impressed with, I must say. So the project has been straightforward in all of its aspects. In terms of sustainability, in yesterday's General Assembly meeting, the planned founding of a legal entity and the S3 process were mentioned. Maybe this particular case of PHIRI being both a public health information body and a policy support body and a provider of important data research infrastructure might require a more modular approach to ensure sustainability of the different elements. The PO is happy to contribute to sustainability discussions. So that's a message for the consortium. Finally, he wanted to share the story of the making of PHIRI and how it happened to be. So it is quite a story by itself to tell, with interesting lessons learned for him. It turns out that 5 major ingredients are needed for a straightforward, fast setup of a new research infrastructure. A demonstrated need, not surprisingly, a valid concept, persistence, a pandemic, and a slow-moving Belgian train. So now you're going to find out the full story. So on the demonstrated need, work under Santé-supported bridge and, in fact, joint actions showed the need for structured data evidence to underpin monitoring population health and informing policy. On the valid concept, workable concepts for retrieving distributed real-world data for monitoring population health indicators were available at national level in several EU countries. And persistent, the network who became the consortium, so the network representatives persistently pursued over many years several EU-funded opportunities to raise support for the envisaged health information research infrastructure, with little success and many drawbacks to sustain. Finally, the COVID pandemic struck, so this turned the situation into more urgency, so the EU policymakers and programs were desperately looking for a EU-level information on the new major health condition to monitor. Funds became immediately available and fast-track mechanisms were used to set up projects and infrastructures that could help. The IMFACT network, comprising public health and health information bodies from most EU countries and associated countries, became the natural addressee for a special and targeted Horizon 2020 call to identified beneficiaries. So that was an exceptional action. And then finally, the slow-moving train. It was about half a year before the COVID struck when the project officer had the chance to interrogate during 3 hours train travel between Luxembourg and Brussels, the then director of the Public Health and Epidemiology Institute at Cienzano, Herman van Ooyen, about the advanced capabilities for collection and analysis of dispersed health data available in some EU countries, something to be scaled up at European level. So this is when Andreas learned about this. Such a patient and personalized training helped point the PO and the Commission services to what could help when solid population data was needed on COVID and best practices as well across EU countries. Then this information became crucial for managing the COVID pandemic. So once more, thank you for your dedicated work, and I see bright perspectives for PHIRI for the future.
I think these are beautiful words. Thank you so much for sharing them with us, Jana, and thank you, Andreas, who is maybe following us online. And then I think Ninka surely wants to reflect also on that with some final words. Yeah, I think it reflected very well what we've done in the past years and yeah, how we've come to where we stand now.
Thank you. So up to me to say a few closing words, which is a bit hard now after this speech by Andreas given to you by Jana. Thank you so much for stepping in. So we've heard a lot. I'm not going to repeat everything today because there will be a recording, of course. But I just want to stress that going back to this, the keynote I gave earlier today, that we are there every step of the way. We started with the data together with Enrique and Hannah and a very nice panel provided to you through a regulated regulation, upcoming European health data space there to provide us there with some key elements to make that happen, and then taking it further into the knowledge translation to actually moving forward to build stronger health information systems as a prerequisite for health systems, and of course to inform policy making and to do, I learned a new word today, foresight-informed policy making. So I think it also demonstrates here that there was a need to set up a population health information research infrastructure that focuses on population health. They're already in the big European landscape of research infrastructures. There are already a lot of them. They are quite older than we are. They're addressing different types of health data, but there was no real infrastructure yet. And I think Andreas in his speech listed quite nicely the ingredients that were needed to make it happen. And now after 3 years, we're here. And what are the next steps? So we're looking at our big brothers and sisters in this landscape of research infrastructures, taking a peek and to see how they get themselves organized for us to take the next steps into the future, to support research on population health along every step of the way to reach the top of the pyramid. So I think here I would like to thank all the speakers that were here for their wonderful interventions and some nice points that they were raising. We will be reaching out to you, of course, after, because some of the things that you were mentioning are actually quite interesting. So keep an eye out for emails from us and for calls. I would also like to thank all the work package leads and co-leads that were there over the last 3 years. It was quite a burden to work on the PHIRI project because at the same time, of course, they were managing a very big pandemic, but they all made some time for us to work with us together. And of course, finally, the other consortium partners and of course the coordination team. So together with Barthélemy and Sasha, Miriam, Charles, Andrew, Pierre, Pascal, we are really there to make it happen. And we're building on the shoulders of 2 persons that have been mentioned before. And I would like, of course, to put a little spotlight on them. Herman van Ooyen, who actually convinced our project officer how much research infrastructure and population was actually needed. And then, of course, our moderator today. Thank you so much, Petronil, for making this work, for leading Bridge, InFact, and PHIRI. And under your supervision, we have actually now have a very mature research infrastructure that is ready for the future. So with this, I would like to close the meeting. Of course, there might be some housekeeping things that we'd like to share with you. For example, there's a lunch there. There will be some music played. And for the PHIRI consortium, we would like to take a photo. And probably that will be outside because it's not raining anymore. It's really nice. Okay, I would like to thank you so much for coming and sharing with this very special moment with us. And we will hope to see you again next year, hopefully, to celebrate the next anniversary of PHIRI. Thank you so much.
Stand around a lot like we got nothing but time. And we want what we want, but we want it now. We don't want to wait in line. And we nag a lot, we moan and groan like we know what to do. But I'm here to say if the truth was known, we haven't got a clue. And we all want to live in a kingdom where everything's done right, where the air is clean and the rivers flow, and the future is big and bright. And we all want to live in a promised land, no hate, no tyranny. Everyone's in shackles here, till everyone heard somebody saying all you need is love. It's the answer to the mess. It's singing it a lot easier than living it, I guess. Yeah, I'm here to say if the truth was known, we hadn't got a clue. Now we all want to live in a kingdom where everything's done right, where the air is clean and the rivers flow, and the future is big and bright. Yeah, we all want to live in the promised land with no hate, no tyranny, but everyone's in